Now, I would invite the next topic, keeping the constraints of the time, Dr. Ashish Jain, who had extensive work experience in many of the world-renowned medical centers, has more than 14 years experience in clinical and critical care medicine, teaching and training. He's a certified instructor to many of the skilled courses, and he's also in the executive committee of the ICCM Jaipur branch. I'm sure he is aware of the entire critical care people in the Jaipur scenario. And welcome him for the topic that he has. I think it's on ABG interpretations and the basic arrhythmias. So, Dr. Ashish, please go ahead.
Evening to everyone. Mr. Dr. Ashish Jain, I'm Director and Professor Department of Critical Care Medicine at Manali Hospital, Jaipur. Today, our topic of discussion is interpretation of data, ABG and basic arrhythmias. And in today's talk, I'm going to provide one approach for the interpretation of ABG and cases. First, coming to the anatomy of a blood gas report, you can see there are some measured values like pH, PCO2 and CO2 and calculated values in the form of bicarbonate with the help of Henderson equation. In normal an ABG machine, it measures pH, PCO2 and PO2, but it can also measure like electrolytes, hematocrit, co-oximetries, methyl hemoglobin, fetal hemoglobin and oxygen saturation. Bicarbonate is always a calculated value with Henderson equation, but there are certain other kind of values which is written over the ABG report, that is bicarb standard and base axis. And please do not use them for the calculation or the reading of an ABG because they could be misleading. First thing is to identify the level of oxygenation, for which we need to see the PaO2. And PaO2 depends upon the age, FiO2 and atmospheric pressure. The normal level of PaO2 is from 60 to 100 mm of Hg. And we need to calculate the alveolar arterial oxygen gradient, because of which we can utilize to differentiate the various causes of hypoxemia in any patient. Now, for the calculation purposes, we have to have some normal values of different parameters like pH. The normal value is 7.40, PCO2 is at 40 and PO2 is 80, and bicarbonate we think it is around 24 for the calculation purposes. So how to calculate or interpret an ABG? The first step is to check the validity of ABG. We need to calculate the H positive ion concentration with the help of Henderson equation. That is H positive ion equals to 24 into PCO2 on bicarb. These two values are given in the ABG machine. And then we can use the algorithm table and the logbook. With the help of this, we can identify the level of H positive ion with the rule of 80. Suppose our pH is 7.20, so we will deduct this 20, the two digits after the decimal, from 80 concentration would be. If calculated and measured, both values are similar or approximating to each other, it indicates our ABG is valid and we can interpret the ABG. Now the next step is to know whether patient is having acidemia or alkalemia. It depends upon the pH. If pH is less than 135, it is acidemic. If more than 7.45, it is alkaline. Second step is whether this problem related to respiratory problem or it is a metabolic problem, for which we need to see two parameters. One is bicarb level for the metabolic derangements and carbon dioxide or PCO2 level for the respiratory problems. For the respiratory problems, if we see if primary changes are in the carbon dioxide, if carbon dioxide is high, it is respiratory acidosis, if it is low, it is respiratory alkalosis. Similarly, if bicarbonate levels are low, it is metabolic acidosis, or if bicarbonate levels are high, it is metabolic alkalosis. Coming to the step 3, once we have identified that the primary problem is respiratory disturbance, we need to see whether it's acute or chronic. Acute means the problem starts for a few hours or few days, but chronic problem like COPD, it is there for weeks or months. After that, we should see whether kidneys have started compensation or not. For the compensation, we need to calculate and we need to see the expected bicarbonate level. For every change of 10 in PCO2 level, whether it is high or it is low, the renal compensation for bicarbonate will be like 1, 4 and 2, 5. In acute cases, when the time is less, kidneys has not yet started compensation completely, so the change in the bicarbonate values are low. While in chronic conditions, the kidneys has successfully done the compensation and the bicarbonate levels would be a little bit higher. Step 5, if the disturbance is metabolic, then we need to see it is acidotic or alkalotic depending upon the bicarbonate value. If it is metabolic acidosis, then we need to see what is the level of respiratory compensation. So here we will calculate the expected carbon dioxide level. And for the alkalosis, we will calculate the expected carbon dioxide level with the formula. If the actual carbon dioxide is more than the expected carbon dioxide, then there is hidden respiratory acidosis. Why? Because actual carbon dioxide is higher than the expected carbon dioxide. Similarly, if actual carbon dioxide is low than the expected, that means patient is having respiratory alkalosis. In step 6, once we have identified the patient is having metabolic acidosis and there is a respiratory compensation, we need to know which kind of metabolic acidosis it is. Whether it is high non-cap metabolic acidosis or normal cap acidosis, for which we need to calculate the anion cap. The formula for calculation is sodium minus chloride plus bicarb. The normal level of anion cap is 12, or we can say 12 to 14. If it is more than 12, then it is high non-cap metabolic acidosis. If it is less than 12, it is non-cap metabolic acidosis. Here are, you can see there are few reasons for the high non-cap metabolic acidosis. This metabolic acidosis levels are also, this anion gap level is also dependent upon the level of albumin in the blood. Then the step 7 depends upon the delta gap. Delta gap means the gap from a anion gap minus 12, that is called the delta anion gap, and delta bicarb, that is 24 minus bicarbonate level. So if delta, generally in a normal patient, delta anion gap should be equal to delta bicarbonate gap. If delta anion gap is high, that means metabolic acidosis is also associated with metabolic alkalosis. And if delta anion gap is less than delta bicarb, it means metabolic acidosis is associated with non-anion gap metabolic acidosis. So two kinds of metabolic acidosis are present: high anion gap metabolic acidosis and normal anion gap metabolic acidosis. These are the few causes of metabolic alkalosis, and to differentiate between these two types, we need to look for the urinary chloride. If urinary chloride is less than 20, it is chloride responsive metabolic alkalosis, and few causes are vomiting, anti-suction, cystic fibrosis, or remote diuretic use. While if chloride level is high, then it could be current diuretic use, potassium supplementation, depletion, exogenous alkali, Bartter syndrome, or hyperaldosteronism. Now coming to few cases. Case 1 is a 30-year-old female who presented with sudden onset of dyspnea. So what should we do first? We should check the validity. If you see here, the pH is 7.52 2. So if we calculate by the rule of 80 minus 52, expected PCO by H positive ion level will be 28. Similarly, with the equation 24 into PCO2 bicarb, the H positive ion concentration is coming around 30. That means both of these values are approximating each other. We can say the ABG is valid. Case 2, a 60-year-old female, a male smoker with progressive respiratory stress and hypersomnolence. So pH is less than 7.35, it is acidemia. PCO2 is high, it is respiratory acidemia. Acute or chronic, with the calculation we came to know it is chronic respiratory acidosis. And for the compensation is almost normal compensation, full compensation, so it is pure respiratory acidosis and associated with hypoxemia. The anion gap is normal, that means it is this hypoxemia is because of hypoventilation. Coming to case 3, it is a case of 18-year-old male asthmatic, 3 days history of cough, dyspnea, and orthopnea, but he is not responding to use of bronchodilator. The ABG showed a pH which is 7.23, that means acidemia. PCO2 is high, respiratory acidemia, acute or chronic. With the calculation, we came to know it is acute respiratory acidosis. So, with that, we need to calculate the expected bicarbonate levels. And if we see the bicarbonate level expected are 26, while actual bicarbonate are 24. That indicates that there are hidden metabolic acidosis. So we calculate the anion gap, and anion gap is coming 16. That means this patient is having acute respiratory acidosis along with high anion gap metabolic acidosis with hypoxemia, with very high alveolar arterial oxygen gradient indicating there is severe hypoxemia. Coming to case 4, a 20-year-old diabetic with respiratory distress, fatigue and loss of appetite with a pH of 7.23, that means it is acidemia, bicarbs are low, PCO2 is also low, it indicates metabolic acidemia. For the metabolic acidemia, the expected carbon dioxide level would be around 27 to 31 and we have 34. So patient is having metabolic acidosis along with respiratory acidosis. Gap, if we calculate, it is high anion gap metabolic acidosis. And if we check the delta anion gap and delta bicarb, it indicates that the delta bicarb are higher than the delta anion gap, indicating it is associated with non-gap metabolic acidosis also. Now coming to interpretation of the basic arrhythmias. So what is ECG? ECG is a representation of electrical events of the cardiac cycle. And we know that generally the electrical activity in a heart originates from the SA node and which has an intrinsic rate of from 60 to 18, followed by AV node which has a backup rate of 40 to 60 and a ventricular cells which has an intrinsic rate of 20 to 45. This is a normal ECG waveform where we have P wave which represent the atrial depolarization, that means contraction, QRS complex which represent ventricular depolarization and atrial relaxation, and T wave which represent ventricular relaxation or the resting phase. If we take a 12-lead ECG, we have chest leads as well as the limb leads. So these leads indicates different portion of the heart. Lead 1 and AVL shows the lateral portion of the heart, while 2, 3 and AVF indicates about the inferior portion of the heart. V1 and V2 indicates towards the septal pathology, V3, V4 anterior, and V4, V5 and V6 indicates towards the lateral wall pathology. For interpretation of ECG rhythm, there is an algorithm, again a 5-step approach. First, we need to see the heart rate, rhythm, E wave, PR interval, and then QRS complex. For the calculation of heart rate, we need to calculate the large square between two R waves and then divide 300 by the RR interval and you will get the rate. We can also calculate the number of small squares between two R waves and we can divide 1500 by this number of small square to calculate the rate. For the rhythm, we need to see the RR intervals. If RR intervals are coming at a regular distance, that means rhythm is regular, and otherwise it is irregular. So here you can see the RR interval are coming at is same. The QRS complex are coming at regular intervals, which is regular rhythm. And here, if you see, this RR interval is less, this RR interval is high, so it is an irregular rhythm. Then we need to see the P wave. So we have to have 5 questions in our mind: whether this P wave is present or absent. If it is present, are these P waves are occurring regularly, or there is some delay, or there is some dropped P waves, or is there one P wave present for each and every QRS complex? And what is the shape of this P wave? Then we need to see the PR interval, which starts from the beginning of P wave and ends at the start of R wave. The normal duration is 0.12 second to 0.20 second, that means 3 to 5 small squares. And we need to see whether this PR interval is normal, high, or low. Then in step 5, we need to see the QRS complex. The normal duration of QRS complex is 0.06 second to 0.01 seconds. That means 1.5 square to 3 small boxes. And again, we need to see here, this QRS complex is less or smaller, or this QRS complexes are bigger on the ECG strips. And in the last, we can see the P waves also. Very commonly, we can see this kind of ECG patterns, and it is primarily because of the patient movement or loose or defective electrolyte attachment to the chest wall. So we should discard this kind of ECG. The normal heart rate or the normal sinus rate is 60 to 100. Sinus bradycardia is called when the heart rate is less than 60, tachycardia when the heart rate is more than 80, and there is cardiac pause or the sinus arrest also seen. So when we call it normal sinus rhythm means that each and every QRS complex is coming at a regular interval. If normal P wave is present, followed by a QRS complex, PR interval is normal, QRS interval is normal, P wave is there, and RR interval is also normal. Sinus bradycardia indicates the rate is less than 60, but the rhythm is regular, P wave is regular, PR interval is regular, and QRS complexes are also normal. While sinus tachycardia indicates that the rate is high, more than 100, but the morphology of QRS complex and different intervals are normal. Sinus arrhythmia, we say sinus arrhythmia is a normal variation in the beating heart. It generally seen during the inspiration and expiration. Here, the QRS complex is normal, but the rhythm is variable. That means the RR interval is variable. Then there are certain atrial arrhythmias. What are they? Atrial flutter, atrial fibrillation, supraventricular tachycardias, and premature atrial complexes. So how to identify atrial flutter? Atrial flutter means we can have a number of more than 2 or 3 P waves between each QRS complex. So we can see here, this is a sawtooth appearance, and these appearances are here because of the multiple P waves. P wave, so there are 3 P waves. So the PP interval, the rate of atrial contraction is around 300, but the rate of ventricular contraction is around 72. It is regular or maybe irregular. PR interval we cannot calculate, but QRS interval is normal. In atrial fibrillation, we need to know that it is irregular rhythm. You can see on this strip, there is no P wave. We cannot identify whether there is any P wave or not. The PR interval is variable. The QRS complex is normal. QR duration is normal, but there is no PR interval. So this is called atrial fibrillation. It is very commonly present in elderly age group of patient. Then the supraventricular tachycardia. Supraventricular tachycardia, the atrial rates and the ventricular rates are high. It's around 200 or 150. P wave are generally indistinguishable. We cannot identify them. PR interval we cannot identify, but QRS complex and QR duration is normal. Then coming to the ventricular arrhythmias. When these ventricular arrhythmias appears, when the SA node and AV node and the junctions fail to generate the impulse, then the ventricles will assume the role of pacing the heart. As there is no SA wave, SA nodal impulses, so there is no P wave, and there is no atrial activity or depolarization. Only there is ventricular depolarization activity. The QRS complex, because it is originating from the ventricle, is wide, or we can say it is more than 0.12 second or 3 small square, or we can say it is bizarre in appearance. So there are 8 kind of ventricular rhythm, and these ventricular rhythms are lethal. First is premature ventricular contraction or PVCs. Here you can find in a normal ECG pattern some broad complex appears. These from broad complexes does not have any P wave. The QRS duration is big, more than 0.12 seconds. And when these complexes appears after each and every beat, it is called ventricular bigeminy. When this PVC occurs every hour after every third beat, it is called ventricular trigeminy. Sometimes more than 2 PVCs are coming together. These are called couplets. If 3 or more than 3 premature ventricular contraction beats are there, it is called ventricular tachycardia. Then comes the idioventricular rhythm. Idioventricular rhythm is also termed as a ventricular escape rhythm. Here the heart is failing. That heart is not generating good amount of cardiac output. The heart rate is 15, 20 to 40. And we need to act fast to salvage these kind of patient. Similarly, there is accelerated idioventricular rhythm where the QRS complex is big, T waves are absent, but the rate is 40 to 100. Cardiac output is compromised. You need to work very fast. Then comes the agonal rhythms. Agonal rhythms are when the idioventricular rhythm is even less than 20. So you will see few beats throughout the ECG recordings, and generally it is seen after failed resuscitation efforts. Ventricular tachycardia. Here you will see the run of broad complexes, QRS complexes on the ECG. There is no P wave, there is no PR interval. QRS complex is big, bizarre. QR interval is high, more than 0.12 second. And generally, patient does not have pulse. It may be present with pulse, but these tachycardias very early converted to ventricular fibrillation. Then comes the ventricular fibrillation. It could be of 2 types, coarse and fine, where you will see just a bizarre, different shape of white complexes, no PR interval, no Rs, there is no P wave, you cannot identify any morphology of QRS complexes. Patients are generally in cardiac arrest, there is no pulse. And we need to act fast, patient need immediate defibrillation. Then comes the ventricular standstill or asystole. There is no electrical activity. You can say flatline ECG. Here is a special situation where the electricity in the heart is working. That means there is electrical activity, but there is no pumping. The mechanics of the heart is not there. So practically the patient is clinically dead, but there is some kind of rhythm is seen on the monitor, and we need to continue our CPR in this kind of situation. In the last, we should talk about the blocks. Blocks depend upon the PR interval. It is of 3 types, type 1, 2 and 3. The type first AV block is characterized by a long PR interval more than 0.20 seconds. Second degree heart block is divided into two types, Movitz 1 and Movitz 2. In Movitz 1, there is gradual increase in the PR interval followed by drop beat, while in Movitz type 2, there is a fixed high prolonged PR interval followed by missed beat. In third degree or complete heart block, there is complete dissociation of atrial contraction as well as the ventricular contraction. So here we end our presentation. Due to the time constraints, I have to rush, and I hope you will enjoy this presentation. Thank you very much.
Thank you, Dr. Ashish. I know it is a vast topic to be squeezed into one presentation. There are ideally two topics separately, and therefore we could feel the rush that was there in the presentation to finish it in time. But remember, ABG and ECG are both practice-oriented things. Okay, the more you practice, the more you become well versed. And I think you have done justice by speaking on most of the things in the span of time that was given. Thank you,
Yes, sir.
Dr. Ashish.
Singh, sir. Yeah, can you hear me?
Yeah, I can.
Yeah, so we have two questions
We can.
related to the previous sessions. So we'll just take them up very crisply. And then, so one question that popped up is especially which surgeries have massive fluid shifts? Yeah, that is one question. And another question is what special precautions should we take in post-surgery apart from regular ICU care? So I think the second one we have discussed vastly in the Dr. Gitesh Mangal's talk. What special precautions do we need to take apart from regular ICU care? So do you need to shed some more light on these a couple of points? Maybe, will you?
I think this question is addressed to the previous speakers.
Yeah. Yes, sir.
Or to
Dr.
anybody in the
Gitesh
audience.
Mangal. Gitesh, sir, I think he has left. Uh, Yeah, but the crux of the story, I can discuss it over here. The crux of the story, post-surgery patient, apart from regular ICU care, we need to focus on early enhanced recovery care. We have a separate topic tomorrow coming on the same topic. As I elaborated earlier, that Indian patients are different from the Western world patients. So surgical outcomes are also going to be different from the Western world patients. We have more and more of like we have a less physical capacity, less muscular mass built up patients in our country. So we need to focus more on rehabilitation and nutrition care in apart from other routine care that we provide to the patients. And massive fluid shift surgeries are basically the surgeries that require the direct openings of peritoneal cavity, maybe, or maybe thoracic cavity. Large surface area need to be exposed in massive fluid shifts, if you ask it in other ways, conceptually. So, since over to you, you can go ahead and introduce our next speaker. Let me share the
Okay,
screen for Dr. Shubhendu.
please share the slide.